Hello, everyone. Welcome to this online virtual panel from the Logic on innovation in healthcare. We have an all-star group just waiting in the wings to talk to you, and I'm excited to get to them. But I know that just because of the enormous response we've had to the invitations to this, that there are a lot of newcomers to the Logic or people who might have heard of us but not know the details. So I'll give you a quick rundown. We're an independent digital news publication with reporters across the country. We cover innovation in business and technology, from electric vehicles to cryptocurrency to agriculture to what goes on in retail. And today we are bringing you an event that is open to everyone. All you have to do is sign up. But for our subscribers, we have a daily newsletter, daily features and news scoops, and subscriber exclusive events that you can only join when you join the Logic family. We have company sentiment analysis, we have surveys, we have a dedicated Slack channel, and job postings. So if you're not a subscriber yet, there are reasons besides this discussion to become one. My name is David Reevely. I'm an Ottawa reporter for the Logic. I cover health policy and healthcare. In a previous career, I was a provincial affairs reporter in Ontario, which means to a significant extent being a healthcare reporter because of how much money our government spend on healthcare. It is a giant public expense and a giant private expense. And it is a service that all of us will use at some point in our lives. Only a little bit if we're lucky, an awful lot if we're a little less lucky. Our loved ones will depend on it. And so we all have a huge stake in seeing it done well. But if you've had a lot to do with the health system in your life, you know that there are certainly some things we could be doing better. And that's what we're going to talk about today. Everyone who is taking part, you can ask questions and I will try to thread them into the conversation or just ask them directly. You can do it in the chat or under the question section at the bottom right hand of your screen. Please do. The more we talk about the things that you want us to talk about, the better this is going to be. I want to give a big thank you to Pfizer Canada, which is the sponsor of this event. They get no say in what we talk about, but they have invested in this to make it open to the public. So before we begin the meat of the discussion, we're going to have some opening remarks from Najah Sampson, who's the president of Pfizer Canada. I've talked to her before. She's a pretty amazing person. She has worked at Pfizer for 20 plus years. She's been a commercial leader in all levels of the organization. She's been the vice president and chief of staff to Pfizer's president and CEO. And now she has her own command at the head of Pfizer Canada here. She's the first woman to have that job. So I will turn it over to her to frame this discussion for us.
Oh, David, thank you for the introduction. It's a pleasure to be here today discussing the intersection of healthcare and technology. It's an area that we all have to be invested in. I'd like to start off with just a quick reflection on why we're here. I want you to think back over the last 3 years and how much has changed both in our lives and how we engage with the healthcare system. In early 2022, I was actually in New York City. So every day I heard the sirens, they felt nonstop. But I also stood out on my balcony with other New Yorkers every day to recognize the contributions of our healthcare workers. Globally, we worked nonstop with overwhelmed hospitals and with providers that were facing critical shortages of medical supplies. We truly felt like our healthcare system was on the brink. Healthcare teams were burning out. Our consumers were really growing wary of medical advice from once trusted sources. But throughout all of that, there were silver linings. Healthcare providers, large and small businesses, and our tech experts really rallied and collaborated to find solutions. There was an urgency there that allowed us to take thoughtful risk and bring a greater sense of equity and transparency to our healthcare system. Telemedicine finally became a reality after years and years. Patient portals for healthcare data were now the norm. And most importantly, healthcare professionals were given more digital tools to better manage diagnosis and treatment decisions. So initially, this was specific to the pandemic. We had COVID testing, there were healthcare services, the vaccine availability, but this idea of transformation through collaboration and technology lasted. So I guess where do we go from here? That's the big question. And how do we maintain the momentum and the willingness to continue this digital transformation in healthcare. So at Pfizer, we've seen that amazing things are possible when stakeholders in healthcare, our researchers, manufacturers like us, providers, and the tech community all work together towards a shared vision. It's one of the reasons why we're so excited to launch the Pfizer Canada Healthcare Hub in partnership with Communitech. We believe this is one step forward to bring together the best and brightest of Canada's tech industry to champion better healthcare. So what is the Healthcare Hub? I'd maybe just spend a couple of seconds on that. Earlier this year, we issued a call for technology solutions to meet challenges in 5 areas: vaccination, drug shortages, access to medicine, women's health, and oncology. The winning entries receive support from Pfizer, ranging from in-kind support to significant business donations to help design, develop, manufacture, and scale their respective solutions. And just this week, we announced the first cohort of winners, along with a commitment to invest $1.4 million to help bring their solutions to market. So our goal is just to ensure that all Canadians have timely access to best-in-class treatments and quality healthcare. And we know we're just a small part of that experience. But it's through these collaborations and investments that we aim to be an accelerator for digital solutions that will enable better care by combining Pfizer's expertise with the tech sector. Today, the Healthcare Hub and events like Logic are our opportunities to really push boundaries and create the future of healthcare here in Canada. We have a great panel today. I'm actually on the edge of my seat to hear their thoughts on how we can harness the momentum of innovation through private-public collaboration and new technologies. So without further delay, David, I'm going to pass it back over to you. You'll be guiding today's conversation. And let me just say that David's reporting about innovation in the healthcare industry is unmatched. And much like today's conversation, I believe pushes the boundaries of what we can do in healthcare. So David, over to you.
Thank you very much for that introduction from Pfizer's perspective and for those kind words. I will not try to talk you out of them. To the panel, we have an amazing group, as I say. We have Dr. Brett Belchetz, who is an emergency room doctor and co-founder and CEO of Maple. And if you were in Canada during the early part of the pandemic, there is no way you missed the explosion in interest in Maple's virtual care platform. Maple came about as a result of a personal insight from Brett. He realized there was untapped potential for licensed healthcare providers to do virtual care in their spare time, get more patients seen who did not have to be in emergency rooms. He's had quite the journey building Maple through wild time to where it is today. We have Brenda Irwin, who is the founder and managing partner of the Relentless Venture Fund, which is a health tech venture capital fund that invests primarily in preventive health and chronic disease management. She's been a VC for many years, and she's a board director. She has been on more than 24 private and publicly traded companies' boards, as well as on nonprofits. And we have Dr. Kamran Khan, who is also a practicing doctor at St. Mike's in Toronto. He's an infectious disease physician, professor of medicine, and founder and CEO of BlueDot, which is an AI-driven company that famously was onto COVID-19 as a major global health threat several days before the World Health Organization was. And he was motivated to get into that by his experience as a frontline health provider during the 2003 SARS outbreak. He's been studying outbreaks of emerging infectious diseases for almost 20 years now, that means. So let's bring up the panel. Welcome. So glad you're all here. I'm going to start by asking Kamran and then Brett in turn. You are doctors, professor of medicine, an ER doc. Most people would consider that, a pretty full life and a pretty full professional schedule. You have each decided, in addition to that work, to go and found your own enterprises. So, Kamran Khan, can you take us through that decision? How you realized that this was something that you needed to do outside the hospital and outside your teaching?
Sure. First of all, David, thanks for having us. Excited to be part of this this really important discussion. So I'll give you a little bit of a brief overview. Yes, I'm still a practicing physician and a professor at the University of Toronto. But probably like most entrepreneurs, I saw a problem and a gap. And that really was about the fact that, the landscape of infectious diseases in the world is changing. And as we just learned the last couple of years, a tiny little virus could disrupt a country or the planet, and that we needed more and better intelligence. So, there were a couple of reasons why I ended up deciding to make that leap of faith. It wasn't because I needed more work to do or I needed another job. It was ultimately that, from a traditional approach in academia, the funding priorities of the various agencies that are out there to fund research, they would kind of go through these cycles of panic and neglect. So that when we had an emergency, there was a lot of resources available. As soon as the emergency was over, those resources started to evaporate. And I would argue we're actually seeing that a bit as well with COVID today. So for me, taking this entrepreneurial path in part was getting out of the passenger seat and really getting into the driver's seat and focusing on what I felt was important, even if the funders didn't necessarily believe that it was important. The second main reason was scalability. And I think I learned after writing grants and kind of doing this work for almost 10 years before founding BlueDot, that there's a limited amount of scale that you can actually create just using the public purse. For funding. So this was really developing a different business model to scale the impact of what we were doing to reach audiences and populations around the world. So for me, it was really just being the pragmatic academic, if you will, and taking what I was doing in the lab and coming up with solutions to deliver it into the real world.
Brett Belchetz, how about you? What was your journey from ER doc to deciding you needed to found a company that would operate outside that part of the system?
Yeah, for me, it was very much based on my real world experiences working on the front lines of our healthcare system. So I would go in, I was an emergency room physician starting in the year 2004 and practiced all the way through to starting Maple in 2015 and still practice from time to time now. But every time I went into the emergency room, I got very fed up with the reality of Canadian healthcare, where I would see patients who were typically waiting 6 to 8 hours in a waiting room to access my time for 4 minutes. And a lot of the time, what I saw is that those people that were coming to the emergency room, many of them were not coming for things that would typically be considered emergency care. Many of them were coming with problems that should have been best addressed in a walk-in clinic or by their family doctor, ideally, if they had one. And I would routinely ask patients why they were there. And, the answer, you'll hear a lot of people talk about, people are abusing the hospital system and, it's just too convenient, et cetera. And that was really never the reason. The real answer people were coming there is because they had nowhere else to go. And what became very clear to me at the time, back, around 2010, 2011, was that wasn't the experience of my friends and family members. All my friends and all my family members, when they had a medical problem, their immediate action was to text me. And what I was finding is I was able to very effectively solve most of their medical problems by text message, by FaceTime video. And it occurred to me that this was incredibly unfair, that if you had the right friend or family member in Canada, you got access to this amazing thing called virtual care. And B, it was very clear that this was effective, that it actually worked. And so to me, it was very clear that we needed to come up with some innovation that would bring this kind of healthcare availability to all Canadians, that it wasn't just those lucky enough to have the right friend or family member. And the reason why I struck out on my own is over many years in the hospital system, there were any number of ideas I had to try to work within the system for how we could innovate the system, how we could more effectively use the resources of the physicians and nurses that we had, how we could improve productivity. And what I found over and over again within the hospitals that I worked in was that typically our healthcare system is a system of no, meaning that whenever you have an idea that is innovative or different from the way things have always been done, there are a dozen people that will line up to tell you why the answer to that innovation is no, why it can never, ever work. And even with the idea for Maple, when I first started telling colleagues that I had this idea to expand virtual care, I was just told by everybody that will never work. And the reason for that was because governments at the time had no public funding for virtual care. And so everybody said, you're wasting your time starting this company. And so it became very clear to me that in order to innovate in our healthcare system, we had to step out of the healthcare system. We had to strike out on our own, build our own innovation. And that was the only way that we were going to make it happen.
I want to dig into that in some detail, but I also want to get Brenda Irwin in on the discussion. You've had experience, we talked last week, you've had experience of the hospital system from kind of the opposite perspective very recently. First of all, tell us a little bit about what you've been through and some of the lessons you've learned from it as someone who supports health entrepreneurs.
Well, the experience is still a little raw. There's a good news end here, but I spent 28 days in the ICU with my younger brother in Toronto. I'm based in Vancouver, and of those 24 days, he wasn't speaking, but I had the privilege of being able to listen in on morning rounds every single day with the ICU team. And it occurred to me, and when I was speaking with David last week, that I was always looking at how are they using technology? How is communication happening? What's happening in this room? What medical equipment? Who's supporting this? And at the end of the day, all I cared about was him getting better. And I witnessed things that I'd never experienced before. I never really thought through, such as ICU delirium, and that's a devastating experience that I don't wish on anyone. But I also just wanted him to get better. And from a technology perspective, I could sit there and I could analyze, well, I know the following could be used here today, but I'm not opening my mouth about this. I actually just want to see how this team works together and executes on the next plan, and being able to ask questions and be curious and understanding a lot, but not all of what was being discussed across the team. I just sat back and I said to David, I feel like a bit of a hypocrite because I didn't see and I didn't desire the introduction of technology beyond what already existed in those days and in those weeks. And it's really caused me to reflect because I've also been on the board of a healthcare organization, Providence here, and I've watched the challenges. And what really stood out to me, and what Brett just said is there's too much. There's a system of no to even consider innovation and bringing it into care environments. So I have a lot of thoughts to share around that, but I will say one other thing that from my own experience in the hospital system, a couple of years ago, I was hit by a car while riding my bike, and I was discharged after 22 hours in the trauma ICU out west here, without a diagnosis of the multiple spinal fractures and pelvic fractures that I had. And I'm haunted by that. And I think about that often in terms of how could technology have played a role versus my own experience in knowing my body that actually catalyzed me getting the diagnosis and finding out is like, how am I discharged from a hospital with multiple sacral and pelvic fractures and not a mention that might have been the case? That is another, very personal firsthand experience that I think about often about where could technology have fit in that specific experience.
Have you got some answers to that question about where technology could have?
Absolutely, and I would say that AI is, I'm sure, going to show up a lot today in conversation. But I just think as an adjacent tool, not as a replacement, in terms of being that second step from a verification. Like radiologists are experts, but they miss things, and in this case, going into a different layer of care subsequently, it was fascinating to me to even layperson here look at my own images and go, how was that missed? So AI for sure is going to play a role in diagnostics. It already is, and I think what I hope is that there are going to be more providers, both at an administrative level but also at a user level, that just find the space to explore how these new tools really, really could be integrated into the care process.
Kamran, let's take up the AI question. As someone who is, I think, physically in a hospital right now, and has expressed frustration at integrating some innovative ideas just into the practice of medicine generally. Is AI like a big enough thing to break through those barriers?
Well, where I'd go with that is, I think, Brett talked a little bit about, the finite human resources and talent that we have, and how do we extend that. Brenda, you talked about how something was missed. And I think you also said, this isn't necessarily going to replace the human, but it's going to augment human capacity and capabilities. I think one of the real challenges that I see, just from where I'm standing, and, I'm, in the ICUs in the same way that you were just describing on a day-to-day basis, is that the healthcare staff today are cognitively overloaded, and that this is not making it a justification for your experience, but folks are stretched very thin. I think the pandemic has led to attrition. We've had people leave the field early. We've had attrition in terms of not just physicians and nurses, but allied health staff. And with an increasing complexity and volume of patients that we're dealing with. So I do think that AI is going to play a really important role in augmenting the capabilities and extending the abilities of our human talent. This is something that there's clearly a lot that's happening in this space right now. But I do think one of the really important challenges is making sure that AI is integrated into the workflows of healthcare providers. It's one thing to generate an insight. It's another thing for it to actually be an actionable insight integrated into your day-to-day workflows. And that requires getting these innovations into the healthcare system. And I think what I heard both from Brett and Brenda, and it's certainly been my experience, is that one of the most difficult things is actually even getting adoption in the healthcare system. Mm-hmm. So we have an amazing depth of talent. I'm, based here at the University of Toronto. There's a depth of talent in AI. There's an incredible depth of talent through the faculty of medicine here. But ultimately, we need to get these innovations into the healthcare system itself. And that is still a very, very significant barrier.
So, Brett, you've had some, I think, parallel experiences with that. Maple significantly predated the pandemic, but you had some difficulty getting traction, and then suddenly that was the only way, almost the only way, to see a doctor. Do you see parallels, lessons from the pandemic that can be applied to incorporating artificial intelligence into diagnoses, into treatments?
Well, I think if there's one lesson that we take from the pandemic, and I think this is probably, unfortunately, one of the clear paths forward for innovation in healthcare, it's that healthcare is a bit of a rock. It doesn't move very much unless we are in a state of true crisis. And I think that was mentioned already in this discussion, in that when we've had times of true crisis, be it SARS, many years ago, be it COVID recently, we've seen mountains be moved all of a sudden. And then when these crises abate, typically what you see is a culture very much of inertia. And so I think when we look at AI, I think one of the things that is going to really force the greater adoption of AI in the delivery of healthcare is going to be the ever worsening crisis in terms of the delivery of healthcare in not only Canada, but around the world. Everywhere we look in the world, what you see increasing demand for healthcare, aging populations, and a smaller population of younger healthcare workers that are going to be delivering the care in the years to come. And those numbers don't add up to a good place in the years to come. And so that state of crisis is going to force healthcare systems around the world, hospitals around the world, governments around the world to think about new ways of doing things. And Kamran was very clear about that. He said, we have a very limited pool of human beings, and we need to figure out how to get more out of that pool of human beings. And I think AI is going to be one, not the entire solution, but it's going to be one of those tools that's very much going to help us.
I'm interested in what you said about this being a worldwide problem. I think it's probably true of just all people everywhere, but certainly in Canada, we tend to focus a bit on our navels when it comes to healthcare, and the idea that our whatever provincial or territorial health system we're in is uniquely bad, and get very mad at our health ministers and premiers about it. Where do you think the Canadian experience, how does it compare to what's going on in peer countries like the US or Britain and other comparable countries?
Is that a question for me?
Yes.
I can jump in. Yeah. So I would say it's clear, all countries are struggling with this. I would say Canada is It's definitely not performing well compared to international peers. So a good resource for anybody to look at is something called the Commonwealth Fund. It is a think tank based in the United States. I think they're based in Washington, D.C. And every year on an ongoing basis, they rank healthcare systems around the world. Typically what we see, what they're looking at is all the developed world nations that they compare. Typically we see Canada performing either worst or second worst in the developed world around things like access and equity of care. The only system that tends to perform worse than ours is the system that serves uninsured patients in the United States. So I would say we are, this is a challenge affecting the entire world. Canada is faring worse than almost anyone else. So that concern that's being directed towards our ministers of health and our government is certainly, I think, appropriately directed, in that there are much better outcomes being seen in some of the European nations, some of the Asian nations than what we are able to achieve, and they are not spending more money than we are. So there's lots of lessons from other parts of the world for how to deliver healthcare more effectively, but that doesn't change the demographic time bomb that everybody is facing.
Brenda Irwin, I see you nodding a little bit, and I mean you have portfolio companies that presumably don't only do business in Canada, or maybe only barely do business in Canada. What does that look like from your perspective, dealing entirely with people trying to sell to health systems?
Well, the brutal truth is that the majority of innovators go to the US to get early traction, and the primary reason is they know who's going to pay for it. So a lot of innovators and entrepreneurs that have the wisdom to see developing relationships with payers in the US is one of the key differentiators for them in the market, because one thing that I think is misunderstood in the Canadian ecosystem, in my experience, both being on boards of hospital organizations as well as actively in the trenches, is we don't have time for the pilot paralysis to be over years. We need to shift the culture, to find ways to have more living labs and test in local ecosystems. And a lot of that support, mentioned earlier with the new healthcare hub that Pfizer's sponsoring with support of Communitech. I mean, that's exactly the type of additional capital that's needed to move innovation. And it's frustrating, but I mean, statistically, I was going through my current portfolio and I could only identify 2 of 9 companies that actually have a product that's ready for commercialization that started in Canada. And that is 100% because of the issues associated with who's paying for the care. And also, if I use an example, and this is one that is very, very sensitive for me and many, is mental health care. And I think Brent said, made reference to emergencies, right? Like there's an emergency response, and then there's capital and programs that show up, that did during COVID around mental health. And then there's the attrition of support. And we're talking about tens of millions of dollars to try and get people who were seeking support, and with the stigma being less now in terms of securing that support. Well, in the US, I was just yesterday talking to a Canadian startup who is spending all of their time in the US because the federal government put forward $500 million for resourcing counselors in the school system. Imagine what the culture shift would be if we had more capital going to mental health support in the earlier stages and also preventatively. And his response was, I'm going there because there are pots of money, low-hanging fruit, people that are trying to bring these resources together in an environment it's not existed before. That's a lot of money, and it is the right place to be allocating it.
So folks, worried about the halfway point, bring your questions in so we can get to as many of them as we can. The more the merrier. Kamran, I want to ask you to take up some of the points that Brett and Brenda have just made. I mean, first of all, I mean, you talked about the panic response and the sort of subsequent withering. I'm going to ask you, are there times when innovation and improvements have come outside that boom bust sort of cycle that you can think of?
Well, look, I'll speak from my own experience in the area of infectious diseases and epidemics, and this has kind of been, my career over the last 20 years or so. But I would agree with Brett that the healthcare system isn't necessarily particularly adaptable. It doesn't move very easily outside of a period of crisis. I think when we look to the pandemic, the early days certainly there were heroic efforts made across the board. Not only from frontline healthcare staff, hospital administration, everyone across the board was really moving mountains to try and get things done quickly and efficiently. But I do think we are subject to this cycle that we've been talking about, this cycle of panic and neglect. We preach prevention in healthcare, but we actually don't necessarily do it very well. So a lot of the innovation, unfortunately, is driven by a crisis. And I think what I worry about today is, we're already seeing some of that neglect start to take place on the, as we're out of the worst of the pandemic. So I would say that it is quite challenging to innovate and disrupt during a period where there's relative stability. There isn't a crisis right in front of you. I do want to, without being an alarmist, I do want to really highlight that I think the world is far less stable today. I worry about the issues of, the next outbreak is probably on the horizon. We've had 7 global health emergencies in 14 years. So according to that schedule, we're actually due in 2024 for another emergency. Probably not what folks wanted to hear. We've got more humanitarian crises. I work in the area of refugee health, so I see immigrants and refugees who are displaced from around the world with a variety of infections. And then we have humanitarian and environmental crises that we're also dealing with. So I think there's going to be a growing set of pressures on the system, but I think there's not a whole lot of give in the system, and there's not a lot of resilience. But the necessity for innovation, we need to be using every day of peacetime to be preparing for these surges that are coming.
Brett, you have, you're based in Toronto, but you have a pan-Canadian perspective working with health systems across Canada. Which ones still that you deal with still seem seized with the urgency of the moment? Who's doing a good job on looking for the next thing, getting it in?
It's a great question. And what I would say is it very much correlates to what we've already spoken about in this discussion, which is that necessity and crisis is definitely the mother of invention and innovation, particularly when it comes to healthcare. So, when we look at the landscape of healthcare in Canada, a lot of the geographies that have been most challenged in terms of access to care are the maritime regions of Canada. And as a result, what we've seen over the course of the last, 8.5 years since we started our company is we've seen the most willingness to embrace innovation, the most willingness to do things differently amongst those provinces that are located in that part of the country, because more of the status quo was just not an option for them. We've seen lots of articles from, be it Nova Scotia, New Brunswick, et cetera, Prince Edward Island, running out of doctors, emergency rooms being forced to close, people who can't get family doctors. We're talking about massive swaths of the population. So innovation was their only option. So we've had tremendous opportunities to scale up very, very effective programs across the Maritimes to help with these problems, to help keep emergency rooms open, to help keep hospitals open, to provide patients across provinces that don't have family doctors with family doctors. The spirit of innovation in the Maritimes is phenomenal. And one thing that I'll say as well, which has been incredibly helpful in that part of the country versus what you see in other parts of the country, is that decision-making is much more concentrated. So for me to go into, for instance, the province of Nova Scotia and get a decision about, are we going to roll out a program for everybody without a family doctor? There's a very small number of people that can fit into one room who can make that decision. So we can do these things efficiently. When we look at a place like Ontario, there are just dozens and dozens and dozens of decision makers scattered across multiple departments in multiple parts of the government. And it's actually often indecipherable who the actual decision maker is. And as a result, even projects that are clearly the right ones to move forward with, it's impossible to get them to move forward.
Is that a function of the size of the province? Like, is that an Ontario, Quebec are some of the worst and PEI is the best? Or is there something more about how the systems are constructed involved?
I think it's size, but it's also, how is bureaucracy structured? You can have very, very large organizations that have very well-structured decision-making processes and very clear apparatuses that point out for any given issue, who is going to be the ultimate decider. So I think the responsibility lies in several areas. I don't think it's quite as simple as just, big versus small.
Okay. Got some questions from the audience to draw on, and I'm going to throw the first one at you, Kamran. And it comes from Jacqueline Baptist, and thanks for it. How do we incent, either at the hospital level or at the broader system level, or for that matter at the national level, organizations to be more innovative, to say yes to things instead of by default saying no?
A great question.
Question. If you can toss off a 30-second answer, that would
sure. I guess I would say there, when we think about an innovative system, everybody has to be willing to take risks. I think I'm seeing more physician entrepreneurs and healthcare entrepreneurs willing to take risk. I think, we're seeing more hubs at universities like CDL and the Health Innovation Hub and so forth to help support ideas turning into innovations, non-dilutive capital, venture capital. But I think the big challenge really is that the healthcare system itself isn't necessarily willing to test these innovations and co-develop them so that they are actually implementable in a real world setting. And so that is one of the biggest barriers. I don't think it's even necessarily just a procurement problem. I think it's a cultural problem. We're not even talking necessarily about hospital having to procure or pay for a solution, but just to actually test the solution out and work with the innovator to further refine it, to make sure that it can be further refined and actually be usable in a valuable, meaningful way. I see this as really an important cultural area, but I'd be open. I'd welcome hearing other folks' perspectives on this.
Brett, you want to have a go?
Yeah, I think it's probably not the right role, to be honest, for hospitals and entrenched providers of healthcare in the system to be the place where initial innovation occurs. You're looking at a necessarily risk-averse part of healthcare delivery, and that's because if you're a hospital delivering ICU care, emergency care, surgeries, if you screw things up, the repercussions of that will be very, very serious. So typically, what we see is hospitals, we see ICUs, we see large health authorities, we see them adopting innovations that have already been proven outside of the system. And so when we think about how do we incent innovation in the healthcare part of our economy and a healthcare part of our society, I think the right way that we do it is actually we create a playing field that allows parties that are outside of the healthcare system to successfully innovate and to successfully show that those innovations are safe and effective at scale, so that it is then very easy for hospitals, for health authorities, et cetera, to then procure those solutions. So I think what's missing in our system is the whole network of supports that say, for that individual or that entity that's very entrepreneurial, has a great idea that's innovative, for them to go from idea to scale to then have the traditional healthcare system feel confident in adopting it.
I want to maybe provide a counterpoint there, Brett. I think it's about culture and different hospital ecosystems embracing innovation in a way that is internally driven, and that's really hard to find internal champions versus external parties wanting to push products. I made a comment earlier about pilot paralysis, I think, and the challenge is, but the opportunity is, you find the right internal groups in a program where you can at least get some initial traction that then gets communicated to a broader audience, and then also internal communication in the healthcare ecosystem. I remember when I was chairing, it was the first time there was an innovation committee of a board at Providence, and the physician response was, oh, more money for me in my existing programming, versus we were trying to look at how do you bring external private public partnerships and elevate what exists and bring in new ideas. And it was just a basic misunderstanding in terms of what the goals were. I think I've definitely seen success, and I've also seen an example where an external group proved a shorter time to solution for this particular patient population and reduce costs. And it was wholeheartedly rejected to be integrated because of the existing legacy EHR, EMR system. Like that's just a practical reality. So when innovators are looking at bringing in technology, instead of just saying there's not a chance I'm going to ever integrate, there are ways and success stories where companies have figured out how to bolt on, for lack of a more elegant term.
Kamran, you want to add?
I was just going to briefly say, we talk about public-private partnerships. I do think, going back to this issue of culture, I do think that there's just a lot of discomfort with the concept of a public-private partnership. That's been certainly my experience. And I think in healthcare, there's a unique opportunity for us to be thinking about doing well as a means to do good in a sustainable and scalable way. But I think it's just from a cultural standpoint, I think there's a lot of discomfort with that's from my perspective, at least what I see from my vantage point.
So I want to get the two doctors' perspective on this. And I'll start with you, Kamran. BlueDot doesn't do patient care, and that's totally different kind of thing. And I think that is, from my experience as a reporter, that's where people tend to freak out, the idea of paying for care with your credit card instead of your health card. Does the fact that BlueDot doesn't do patient care, does that make you the company an easier sell to investors, to clients, to governments? It doesn't feel like a private partnership for delivering care?
I don't know whether it's easier. I'm not working directly in the healthcare system today with BlueDot, but our clients are governments. As you can imagine, today there's a clear recognition and understanding that a virus could slip across a border and lead to the deaths of millions of people. This is not out of the realm of possibility. It could disrupt the economy. It could create social chaos and disorder. So that's really where BlueDot's business started, in supporting governments around protecting the health of the nation. We've grown our business around the world, actually, and I'd say a lot of that growth has been outside of Canada. But we've also been working with the biomanufacturing sector, pharmaceutical and life sciences companies, because there's a clear understanding that we can't fight these outbreaks with sticks and stones. We're going to need vaccines, therapeutics, diagnostics, personal protective equipment, all of these medical countermeasures that are essential in getting ahead of outbreaks. So I do think, as BlueDot has grown its business, we started out primarily in a B2G, in the B2G space, but we've really started to expand and are working with other sectors in the private sector to really elevate awareness and being able to anticipate where these types of threats are needed, and essentially where those medical countermeasures are going to be needed. So, that's actually been the way that we've evolved, and certainly it has certainly resonated in terms of raising venture capital and so forth. I guess on one hand, we're mitigating risks that are mission critical. On the other hand, we're helping to empower the biomanufacturing sector to make sure that we get all those essential supplies in the right places at the right times.
B2G being a bit of jargon, meaning business to government, right?
Business to government,
BlueDot
absolutely.
To government. If you live in this world, you'd say that kind of thing all the time. If you're a newcomer, so Brett Maple does do patient care. Do you think that makes a difference in either investors' willingness to work with you, or governments or other organizations' willingness to work with you?
No, certainly not investors. I think investors are primarily interested in, is this a place where we have product market fit? Is there a market for what we provide, and does our product actually meet the needs of that market? And I think there's no question. When you look at access to healthcare in Canada, we have the most challenged access in the world, and we have an innovation that absolutely improves access to healthcare. So that fit is there. When it comes to government, primarily, the way that we view ourselves, to be honest, is we don't view ourselves as a patient care delivery company. We view ourselves primarily as a technology company, because our primary innovation is, we are not delivering care that is different from what you would receive from any doctor who is working in their office or their clinic or their hospital. That care is being delivered by clinicians that are using our technology. The primary innovation that we developed is the innovation that allows an existing workforce of physicians. And I think this is a stat that probably surprises most Canadians, but under 50% of Canadian doctors work fully or full-time. And frankly, as an emergency room doctor, I was one of them, because we just get so burned out in our primary care settings that the thought of doing one more shift in the emergency room or one more shift in our clinic is just something that we would have to be dragged kicking and screaming back into the building to do. But there is all this untapped capacity in the healthcare system. And so we view ourselves as a platform provider. We've developed a technology that allows all of that untapped capacity to be used to provide more care to populations. And so what we've seen is we've seen a number of governments that have said, we get that. And what we want from you, Maple, is we actually just want to use your technology. So we have a number of governments that actually just license our platform out, and they're using our technology platform to get more capacity out of their own healthcare providers. And that's been a fantastic model for scaling up in Canada. We have multiple provinces that have province-wide implementations with us. So I would say I'd love to see more of that. There are some parts of the country, unfortunately, where there is that negative association. You're a private firm, that is working in the healthcare space. Let's get very anxious about that versus saying, what can we learn from you and how can we work with you to actually enhance delivery across other parts of the country as well.
There's a question from Brian Simmons that I want to put to you, Brenda, because it's about investment. And Brian says his take is that the investment community in Canada is not that interested in startups that aren't already making money. So what can be done? First of all, attack the premise of the question if you want, because that's the space you work in. But if you agree with it, what can be done to get investors, investing earlier when companies are just at the proof of concept stage?
Well, I've been a biotech investor and a digital health and a med tech investor. So, the world has been unkind from a innovation, adoption, execution, making money. Investors, I have said this before, I'll say this today. Being an early stage venture investor can be soul sucking. What drives me every day and energizes me every day is the goal is to have an improved impact on improving health outcomes. I mean, that is what keeps me going. Investors will invest in quality concepts and innovation when it's clear that the team and the entrepreneurs are coming from a place that is like, I love physician founded companies because they've already generally identified where there's a clear problem that needs solving, versus some entrepreneurs who like the idea of being an entrepreneur and go look for a problem with a solution they've created. I mean, that happens still too often. But I would say that when companies are meeting investors who only want to see revenue, then you keep looking for the investors that do fund the earlier stage investing. And I would say, I have this running list of pet peeves, and one of them is there's no money for investment in early stage health innovation in Canada. It's like, yes, there is. There's just a lot of companies that don't have enough substance from a starting place to warrant venture investing. There are many other programs, and I implore anybody who is listening today where IRAP, SHRED, those are the difference makers for health innovation in Canada in advancing technologies before seeking venture angel investment. We're not the Holy Grail. It's just you need the capital. There are different places to find capital, and just hearing that nobody will invest or VCs won't invest unless they're revenue. It's like, well, that's just a very different profile of a fund. That's fund specific. That's not ecosystem specific.
Kamran?
I'll just just building upon some of the comments Brenda made, just from my own experience with founding BlueDot, in those early days, it was a lot of these other non-dilutive sources of capital that we used to kind of bootstrap. Because BlueDot, in many ways, I founded in 2013. I think we were sort of ahead of our time in the sense I don't think the world quite fully appreciated how disruptive a little virus could be. But a lot of those programs, Shred, IRAP, others actually helped us in the early days kind of build a bridge from what I was doing in the academic arena at the university to laying the foundation. And then, of course, COVID happened, which was, a pretty clear, unambiguous validation that this was a growing problem. But yeah, I would encourage others who are in those early stages to look at some of these other non-dilutive sources of capital if they're having difficulty raising private capital.
It sounds, from what I've heard you all say so far, and I'm going to throw this to you and see whether you agree, but there are kind of two sort of big sets of problems, or two kind of super problems with sub problems, at least that we've talked about. One is entrepreneurs and innovators knowing what the systems need, and just getting some insight into what hospital care, since that's what we've mainly been talking about, is like in primary care. And the second is getting somebody to say yes, and when somebody actually does have an idea. So like there's a sort of wall that each side can't see very well over. Is that Dr. Belchetz, what do you think of that diagnosis?
I would probably express it a little bit differently. I'd say
Sure.
There's lots of innovators who come from either physician backgrounds or other backgrounds that have lots of great ideas for how we could improve healthcare delivery. No shortage of ideas. I think from there, there's two major problems. So major problem number one is, how do you get the initial funding to go from an idea to an actually viable business? And I think that has everything to do with the last question that was asked. And there's lots of pathways forward. Getting access to venture funding in Canada is very difficult. I can tell you that we had exactly the problem that was just expressed. We approached tons of venture capital firms in our early days, all Canadian firms, and every single one of them said no. We'd be happy to write you a check when you're much bigger and much more proven. The reality is, when we're much bigger, which we are now, and much more proven, we don't need those checks anymore. So we were lucky enough to find some angel investors that were much more courageous than the venture firms that we spoke to, and the idea proved itself out. But I think that difficulty getting that initial round of investment to turn into a business is very challenging. But then the other really difficult thing that is faced by almost every entrepreneur that I've spoken to in Canada is going from, now I've got a viable business, I got that initial funding, it's how do we get our first customers? And how do we get our first customers of any real scale? There's this chicken and egg, which is big buyers, who are the ones that you want, are never going to be the first buyers. They're always going to say, I'll buy it when you already show me that you've got a really good proof that this worked with another big customer. So how do you get that first big customer? And this is where we have a really big problem in Canada, in that nobody is willing to step forward and say, we're gonna be that risk taker. We're gonna give you that first contract. We've got funds set aside, be it government, be it corporate, et cetera. We've got funds set aside that will give you that very big first purchase. It's yours to either win with it or lose with it. If you screw it up, that's kind of the end of your business. You clearly aren't ready for the spotlight. But if you do a really great job on this, you're going to have us to then take as a reference point to all the other big customers, and now you're going to get your launch pad. And there's no entity like that in Canada, at least none that I'm aware of.
Can I just build upon that? I'd really like to echo that point, because I think what Brett, you just highlighted, is that first customer. It may not even be a first paying customer. It could be a first user. It could be someone that actually, you develop a case study on. But it is very challenging. And I circled this back to, where we started. We talked about talent and talent retention. And I do think that, I see this around me with some of my peers who are, innovators and entrepreneurs who have decided that it's no longer viable to actually maintain their business in Canada. And so they go south of the border or they go elsewhere. So we're in a bit of this cycle where it takes decades to develop these types of individuals and talent. And again, they're a unique phenotype. Not everyone necessarily who got, a GPA of 4.0 is willing to take a risk as an entrepreneur. That is, there's a significant fear of failure there. But I think the actual healthcare providers and healthcare system are critical players in this innovation ecosystem. If they don't adopt, if they're not willing to test and iterate and be the first set of users or the first buyers, you can just imagine as an entrepreneur going to sell outside of Canada, and the first question would be like, is your own institution using it? Mm-hmm. And if the answer is no, that's a very, very precarious starting point for a discussion.
I'd like to
Brenda?
add, I mean, just the concept of living labs, it doesn't show up enough in the ecosystem, and any institution, hospital, long-term care facility. I know it sounds maybe crass to call it a living lab, but what it really just means is being willing to have a group of individuals who could be patients. I'll focus on Alzheimer's specifically. I'm very familiar with one of our portfolio companies that was trying to just test a product with individuals with early onset Alzheimer's, and they went through a Facebook campaign. And I was like, call gerontologists, go to areas, go to facilities and hospitals that have very specific senior populations where they are willing to bring this in for 12, 20, 40 individuals, and it would be efficient in collecting data. You'd have access to data, privacy is covered, and then they would be the first individuals that also could use it as they refine the product. But living labs and changing culture of embracing innovation in a way that I want to add one additional point is collaboration and consortiums. I would love there to be more groups of innovators that get together and maybe actually 1 + 1 does become 3 versus individually trying to integrate technologies or introduce technologies that could be more efficiently delivered if they brought their ideas together. And I'll just do a shout out for digital and formerly called the Canada's Digital Supercluster. I'm involved in the allocation of that funding. And what I love about the model is the consortium approach, where they ideally include a first customer in that consortium. It's not rocket science to see why that is a much better model when bringing capital and moving ideas forward.
It helps the innovators iterate and gain have the access to the necessary, the customer's perspective, which you can't really innovate in a vacuum. And if you hit on something that works, it's phenomenally lucky. That's not generally how it goes, right?
Yeah.
We're in our last few minutes, so I have a question that I want to put to each of you, and I'll just sort of go around the circle from Belchetz to Irwin to Khan. What do you wish, what's your elevator pitch to the people who make buying decisions, the people who have the money? Grab them by the lapels. What do you want them to know?
So I think I'm first. So I would say number one, first of all, I would say, give those organizations that are Canadian, that are innovative, that have a great idea, give them a chance, even though it's not proven yet. We're one of those organizations now. We're lucky enough that we've been proven out. We get the big deals, but it shouldn't only be us at this stage. There are newer organizations out there that aren't being given a chance. Give them a chance. Two, one of the things that we find, particularly when dealing with government in Canada, continually frustrating. When we go to the table and we pitch a solution that can solve your access to primary care problem. So 20% of Canadians don't have a family doctor. So we pitch a solution for that. We get asked the question, what's the ROI of that? And when it comes to healthcare, it's a bizarre thing that somebody's asking you, what is the ROI of a healthcare solution? If we said 20% of the country does not have a fire department, and we said, hey, we're pitching, let's give 20% of the country fire departments, nobody would say, what's the ROI of giving them a fire department? We would say every Canadian deserves the right to make sure that if their house catches on fire, there's someone there to put out the fire. So there are some parts of society that are not an ROI-based decision. And I think healthcare is one of that part of society. We have to make sure that we get effective results, that we're covering the populations and that we're spending efficiently. But this is a human ROI. This is not an economic ROI in healthcare. So I really want decision makers to think about the human impact they have with the investments they make, more so than demanding a financial ROI from product that clearly can make a difference to so many people.
Brenda Irwin, what's your grab them by the lapels message to the people who control the money?
Understanding that prevention in seniors is real, preventative health. And if I use a specific example of onset of dementia, mental health decline, loneliness, there are so many ways to address delaying mental health decline of our senior population and our aging population. And I really don't think it's taken seriously. And I'm going to throw this one idea: put more money into personal support workers. They're underpaid, and if that was even brought into the ecosystem of care in a more rigorous and sincere way, like, you can't imagine what preemptive mental health care they provide in their role that's outside of traditional healthcare.
Yeah, it's not just about the tech, right? We need the people to do it. Yeah. And Kamran Khan, what's your grab by the lapels message?
I'll complement that discussion about human expertise and intelligence with maybe AI. We're in this incredible era of innovation and new technologies that can absolutely be just completely game changing. So my message would be receptive to testing these out. Like the status quo is not going to get us to where we need to go. I think Brett sort of highlighted, we are headed in a place where the demands are going to be exceeding the capacity that we have for humans to fill all of that need. And so we're in this incredible era of innovation and technology. Be open to doing things differently.
And with that, we have to draw this panel to a close. It has been a joy talking with the three of you. Brett Belchetz, co-founder of Maple, co-founder of Maple. Co-founder of Maple. Brenda Irwin, managing partner of Relentless Ventures, the Relentless Venture Fund, and Kamran Khan, co-founder of BlueDot. And many other things for all three of you besides. Thank you so much for being a part of this. I also want to thank Najah Sampson and Pfizer for putting up the money to make this discussion open for so many of the people in the audience. And thank you all for joining us, for feeding us your questions. Even if I didn't mention you by name, I hope you got some of your inquiries addressed. There were more than we could get to, though, so thank you for all of those. Subscriber support means everything to The Logic, and it lets us produce events like this and others, and do the groundbreaking journalism that you can't find anywhere else. So if you are a subscriber, thank you very much. If you're not a subscriber yet, now is your chance. And if you want to see more stuff like this, you can join the family. You can find a link to subscribe at The Logic's website, which is at thelogic.co. The Logic's business team, Unsung Heroes, put this together, particularly Ariel Lepper-Walker. It was also a treat to work with. You didn't see her here, but this happened because of her. We have, this, I think, is kicking off our fall season. We have any number of other events like it coming up on different subjects. So watch your inboxes for invitations to those. So thank you again to everyone who joined us today, to the panel, to Najah Sampson, to you folks in the audience. It's been a treat. See you next time.